be able to begin.
Perfect. Thank you.
This conference will now be recorded.
So you may begin the meeting, Dr. Fine.
Good morning, everybody. Welcome to the ICD-10 Code Data Review Committee. We're going to start with the minutes review. The minutes were circulated, and I would need a motion to approve and a second.
So moved, Dr. Johnson.
And I see Dr. Reddy seconded, and all in favor say aye.
Aye.
Yep. Any opposed? Hearing none, we'll move on to the tool update. And so I will turn it over to whoever's going to do that update.
Great. I think Stuart's going to do our preview for us. Stuart, you ready?
Yes. So I will actually, Ben, can you allow me to share my screen? I think I need organizer access to that.
Yes, just one moment. We'll, there we go. Okay, Stuart, you should now be the presenter.
Okay, thank you. Brandy, can you hear me? Are you able to talk?
Yeah, I can hear you now. Sorry, I was having some connection.
Sure. So what we were going to do was actually kind of give a little brief little highlight of what the existing tool looks like, and then show what the new and improvement is too, just to kind of get a little sense of how we changed it. So I can go ahead and share my screen, and then Brandy, if you want to just talk really quickly about the existing page, and then just let me know kind of where to drive, and then I can talk. I can speak specifically to the upgraded tool itself.
Sure. Can you hear me, Stuart?
Yes. Can you see my screen?
Yes, we can.
Okay, so this was the previous homepage. This was under the resources section, and it was titled ICD-10 Prescriber Resources. And Stuart, if you could scroll down, it was just some basic information about controlled substance prescribing, as well as a small explanation of MEDs and percentages with the tool below that had the condition search with a calculator. And if you could go down, the tool contained a lot of really good information for percentages of daily doses and MEDs for each one of the conditions. But we wanted to do something that made it a little bit more readable to not only our licensees or to anyone who was coming to visit the website looking for information relating to prescribing of opiates and ICD. So if you keep scrolling down, we also had a section underneath the tool that had links to various resources. It was just for more resources, click here. So we thought in order to make this a lot more user-friendly, as well as to show, the purpose of this tool, we thought we should just revamp the entire web page with a lot more explanation, and kind of just put together a big picture of what really is an ICD-10 prescriber tool and how it can be utilized. So do you want to switch over to the new and improved version?
Yeah, just did. Can you see it?
Yes. Yes. So this is the updated version. This has not gone live yet. We have started with breaking down sections to explain how all this information comes together to present information that's going to be in the tool. So it starts by describing the controlled substance prescribing data by condition, by giving specific information of the administrative code regarding the ICD-10 diagnoses that need to be put onto the prescriptions. And then there's a link to that code section. And then there's also a couple of links underneath there that talk about issuing a valid prescription, goes to controlled substance resources, as well as to the medical board's prescriber resources. Then we flip to the next section, which would be ORS-specific information. So we did a quick explanation of what ORS is, since this is where we are getting the information for our tool, explaining what ORS is, giving a link to the ORS webpage, as well as providing links with updates from ORS for their e-news and their annual reports. You'll see also that there's the self-check tool. It's highlighted. That will be added. We're just waiting for the pharmacy board to provide some final updates. And that will give information for prescribers who are coming to this page, that it gets them that link and an explanation of how they can use that ORS self-check tool in conjunction with this prescriber resource tool that we have. Go ahead and scroll down, Stuart. And then finally, we also did an explanation of an MED. We know that most prescribers know what an MED is. However, we thought it was really important to tie this in because we would have hopefully some other consumers coming to the web page, as well as some other outside agencies or providers just maybe looking for some information. So we thought it would be nice to explain this a little bit more, as well as provide some additional information about where you can go to find morphine equivalent doses, as well as information relating to overdoses with MEDs and some CDC, a link to the CDC healthcare provider resources. And then if you scroll down, Stuart, we get into the prescribing tool itself. And we put in a little paragraph here where it actually talks about how this tool is derived from information, from data that comes from ORS, and from those coordinating diagnosis codes with those prescriptions. So we take everything that we had just kind of bullet pointed and tie it all together and show how all that information kind of comes together and is in this tool. And then Stuart, I'll let him walk you guys through the updated tool and some of the things that he's done to make it more user-friendly and readable. And he did a really great job.
Oh, thank you, Brandy. So yeah, this is basically just a reimagination of what we currently have on our website. This is using the same data source as Brandy said. However, trying to make it a little more visually appealing and understandable than just basically a spreadsheet on a web page. So just for basic functionality purposes, we put in some instructions on how to use the tool and what some of the data mean. That way, if people aren't particularly accustomed to reading charts and graphs and such, they would understand at a baseline what things mean. And the condition search is now a selection Dropbox, so it contains every one of these 60-some combined code groupings that we have in the entire data set, so that you don't need to know your specific condition and what it's called. You can actually search through the entire listing here. But it also does still contain a search box There you can see by the blinking cursor. So you could type in something like the word back to find back pain, or, fracture, things like that, and click on it. And then that will update all of the charts and graphs to reflect that particular condition. So one of the big things that we really added here was this rolling 12-month trends to give a little bit of historical perspective on a variety of different variables. So day supply, morphine equivalent dose, number of prescriptions, and then number of patients. And so just to give a sense of if a given month or if your current month is within the realm of common variation, or if you're seeing kind of a blip. And the idea was that somebody could use this as a prescriber or somebody who's checking on a prescription and be able to check their values against some of these, like the MED and day supply, and kind of understand where it falls in the entire population. So in addition to that, you've got a couple of bar charts on the right-hand side that show the day supply and MED distributions. So that way you can see that, for example, for fractures, the day supply median is 7 days, but then you can also see that about 83% of all prescriptions are written within a 14-day supply. So it kind of gives you a quick snapshot of what the majority of people are writing for in terms of dosage and supply. And that's pretty much it. So
just real quick. So is that per prescription, that red bar that you were just talking, bar graph you were talking about?
is that per prescription?
Yes, or
Is that your question?
or per diagnosis encounter?
This is per prescription.
I mean, that's correct. Is this a real patient?
I'm sorry?
Is this a real thing? Because for fracture, apparently people are writing 28 to 35 day prescriptions.
Yeah, that's what it appears to be.
I mean,
That's whatever the data is that are coming from the pharmacy board, from the OR's ICD-10. So
I mean, that makes you either worried about the data or we got a big problem, one or the other. You shouldn't be writing a 28 to 35 day prescription for anything except chronic opioid prescriptions. I mean, that needs to be looked at. I mean, this is how this tool could be used by us, because to me, that's an outlier. So either the data's bad or we got 12% of people that are 13 if you count the 0.7%. I mean, really anything over a 14-day supply is inappropriate, especially with the new prescribing guidelines. And I realize fractures are in that new prescribing guidelines, but to prescribe more than 14 days to anyone at a time is excessive to me for an acute problem. Do you agree with that, Bruce?
I would say I would agree with that. And one thing I want to mention is we've made all these rules and regulations since I've been on the board. We really rigorously enforce checking ORs, yet the total number of overdose deaths from opioids has actually increased, which tells me a couple of things. I mean, perhaps our approach is wrong or we're doing something incorrectly. But what we do know from data is that if you treat acute pain poorly, that can really lead to addiction in this whole cycle. So I think the most effective thing we could do to prevent overdose deaths is to enforce our acute pain rules. As Dr. Feibel is mentioning, 1 week prescriptions. So you prevent someone from falling down that slippery slope. And that may be an opportunity to protect the public more because it seems the other regulations we've passed haven't been super effective in curbing overdose deaths, but this might be an opportunity.
Well, and I got to tell you, on top of that, I look at that and think to myself, okay, I'm prescribing this and I get this chart. This gives me comfort to say, I'm going to give you a 21-day supply. I'm still well under the mean of anyone who's prescribed, not under the mean, but I'm well within the range of normalcy. If 12% are prescribing for 35 days, me prescribing for 14 or 21 days is perfectly appropriate, which it isn't, in my opinion. So Anyhow, I think that this is helpful data. We got to make sure, first of all, we need to make sure these are clearly marked what these are, so it's easy, because I look at this and I don't really understand it at first blush. And if I don't understand it, I think a lot of people may not understand it. So we need to make sure that this is very readable and very easy to interpret quickly.
Mhm.
And then we should, as a board, be looking at this and trying to pull out this 12% outlier group and really figure out what's going on there. Because either it's miscoded or we got a problem.
So another
And I'm going to
point.
go over that.
Yeah, and another point I just want to mention to Dr. Feibel's point, which is excellent, about appropriate treatment of acute pain. Something you could do immediately without having to do a lot of heavy lifting is in that prescriber resources website stuff where you talk about ORs and the laws and links. You should include a link about the acute pain rules and the expectation of a 7-day script and a MED less than 25, et cetera, because that is something we could just do from the jump. And then we could go through the data later, but I would suggest that.
If you scroll down, I know there's a couple other questions real quick. I wanted to scroll down so that way you could see. So we did add a few things here, and I'm going to go over some of this in next steps. So you guys are bringing up a lot of great things for us to add, as well as a couple of things that we had thought about too. And so as far as immediate information, we had put some information here about the addiction red flags, because if you're looking at this and you're thinking, okay, this is not normal, or if you're thinking, oh, I need to start moving away from this type of prescription, we've got these immediate bullet points at the bottom, and so we can add in the information that you guys had just talked about with the acute pain rules. We'll make sure to add those as an immediate place to click for information, because what we really wanted to do was take kind of the purpose of the utilization of this tool and immediately have information right underneath of it where people could go for follow-up information. Am I off track with prescribing according to these acute pain rules? Do I have a patient who's been on this for too long and the trend is showing that they shouldn't be on this for this condition? Do I need to start tapering them? If I'm a family member and I go on here and I see that this seems out of the norm, what are the resources I need for my loved one, or as a patient myself? So we want to make sure we have those immediate next steps of, hey, there's something wrong. What do we need to do to fix it? And so that's why there's those immediate websites and then additional resources. And then also next steps is working with the pharmacy board on this data itself. The pharmacy board is continuing to take an internal look to make sure that this data is effective and useful and that it's being reported correctly. So that way it's not off, because we don't want to give bad data. So they're working really hard at the pharmacy board to make sure that the reporting of this data is accurate. We will be working on a project with the pharmacy board to shore that piece up, as well as start to look at some of the information that we're pulling from this chart to see, okay, what are outliers? What this doesn't seem right with the prescribing rules. What's going on? So we want it to be very, very educational, but at the same time, we want moving forward to figure out how this tool can be utilized for internal review for various different departments, for investigations, for nurse review, and for working with outside agencies.
Can we go back to that slide, the one before, where Dr. Feibel was bringing out all these important factors? So from 28 to 35 days, we have an increase of prescriptions, which goes to 12.6%. Is it because the fractures have not healed? They are prescribing? Because not every fracture is going to...
Well, yeah, I'm not sure we have that particular level of granular data on this, although I understand your point, and it is possible that there is a percentage of patients that persist with pain. But I think globally, my concern is that this might be a group of practitioners that write it this way and have for a long time, and perhaps could benefit from some education. And they may inadvertently be creating, a problem or addiction in some of these patients. The bottom line is we don't know, but there is an opportunity to potentially improve by looking at it, is my personal take on it.
And I got to tell you also, in all fairness, even if I have a patient that hasn't healed a fracture, that patient is either going to pain management after a certain period of time, and I'm not prescribing that patient anywhere. I mean, I don't prescribe over a 7-day course ever personally, but even with the acute prescribing guidelines allowing me to for certain conditions, but really a 28 to 35 day prescription for anything other than by a pain management doctor, which I can't believe all 12% of these are a pain management doctor, or somebody who is acting as a chronic pain person, doing all the steps, testing urine, doing all the steps that you have to do chronic pain management. I can't believe that's 12% of the fractures being written prescriptions for. That would seem exceedingly high to me. I have one other thing. Is there a way to make on these graphs, is there a way to make after the 7 days, because that's outside the acute prescribing guidelines, is there a way for these conditions that are acute conditions like a fracture, is there a way to make the bars red that are outside of that 7 days and have a little guide at the side that these prescriptions are likely outside of the acute prescribing guidelines? You're not saying anything. They may be chronic patients, so you're not saying that they are, but you're saying to the practitioner, look at this, these are red. So I don't look at this and say, I'm safe prescribing for 21 days because somebody's prescribing for 35. So at least it keys them in to say that these are outside the guidelines of acute prescribing, at least.
Yeah, we could definitely do conditional formatting based on the value. So anything above 7 days, we could do all the same color red or increasing gradients of red as the number of the day supply increases, that sort of thing. So I can definitely do that.
Thank you.
I would think if that's not difficult to do, that would be a useful opportunity for us to pursue.
Dr. Schottenstein had a question.
Yeah. Thanks very kindly. So, when I look at that, I have a concern that maybe there's comorbidity, right? And maybe that there is an auto-population of the diagnostic code, when this prescription is being written, that confounds our data. So, there certainly may be an element that is prescribing for that condition in that way, but I do have some concerns that maybe our data is not as precise as we would like. I have a recollection that ADHD showed up as a diagnosis that was populated for indication of opioid medication, which would make no sense. And so I sort of have that sense too, that there may be comorbidity and maybe an auto-population of the diagnostic code.
I would agree. Michael, you took the words out of my mouth. I had the same thought. I think there probably is some issues with prescribers, but I wonder if that number is accurate to reflect everyone has an issue, or there isn't something that's skewed in the data. A couple other points. I think it's a great tool. Stuart and Brandy, you guys did a phenomenal job. One thing I would recommend is, can we put a video or presentation associated with this? Because I think, as Dr. Reddy and other people point out, there's a lot of data to absorb. And unless you have somebody kind of walk you through it like you kind of did with us, it's a bit overwhelming. And I wonder if it's going to be as effective for the person who looks at it as, here you go, here, figure it out. As opposed to, okay, if you want more information, here's how we'll walk you through it in a video or a presentation.
I agree. Yeah.
Yeah, that is one
Great
of our
idea.
plans moving
Great
forward
idea.
as
Yeah.
well. We're
Excellent.
going to put together a PDF like FAQ that walks you through it. And then the video idea is a great idea as well. So we can add that as our to-do list with the FAQ.
Yeah, the FAQ is great. It's just people like to be walked through things. And if
Sure.
there could be an opportunity for Q&A, in terms of that, that would be great too. One last thing, I think, Amol, you brought up about the overdose death. I think that number can be a bit unfair, because I think that lumps in people that have moved from prescription drugs to things like fentanyl and other things that are on the street that are causing the overdose death because now they're on heroin. So, yeah, I'm not saying we don't have an issue. I'm just saying that the overdose deaths aren't necessarily directly related to overprescribing. They have a genesis in it prior. So again, I'm not saying we don't have an issue. I'm not saying we shouldn't do something. I just want to take, the data we're referring to with a little bit of a grain of salt.
Yeah, thank you. I agree with that as well. And I would tell you that I would think the vast majority of overdose deaths are actually from illicit drugs, not ones that are prescribed from physicians. I suppose that a concern might be is that patient that ended up on the pathway to addiction possibly may have started from an acute pain prescription, maybe. But it's just interesting that we've done so many regulations, and I really hate useless regulations that affect us, and we're not getting ahead of it. Or maybe if we hadn't have done these, it would have been much worse. I don't know. But if there is an opportunity to educate, and it's easy to do, I think we should take it.
Yeah, and I think the volume of prescriptions written and the amount of narcotics out there, have had to have an impact. I cannot believe that has not had a positive impact on the whole situation, because we just don't have new players coming to the table, which has been the problem historically, right? We've created a group of addicts that have had their genesis in the medical field, which shouldn't be the case. That's it. Thank you.
Please go ahead.
Oh, you're very kind. I was just going to say, speaking of, having lots of regulations and such, I think that it would be productive for our licensees if on this website we had a general statement as to the purpose of our collecting this data, just sort of very specifically why we're going down this road, because there may potentially be licensees out there who are saying, why, am I being asked to engage in this additional work with the diagnostic codes? It's just another regulation. I think it could be, productive and helpful if people have a good sense as to, our vision for this project.
Great feedback. Dr. Reddy, I think you had a comment?
Yeah,
and then,
my concern still remains. The licensees and the state medical boards all over the country are doing a good job in controlling the prescriptions, the doses, and the number of prescriptions, but it's not translating into reduced deaths due to opioid overdose, which is very concerning for me. What could we do to address that issue? I know it's a big issue, but we all have to keep thinking about that.
I think that's the $1 million question that none of us can answer, but I think controlling it as much as we can and making sure that the providers that are not complying with the acute prescribing guidelines in a collegial way, trying to get them to comply, and then those who, after a collegial way of trying to get them to comply, still don't comply, making sure that they know there's consequences to their actions might help, because I do agree with Dr. Soin that the gateway to this, ultimately, I've heard many, not always, but I've heard many stories, especially in orthopedics, of people who've had an acute injury at 16 that have been on a little bit of a prescription opioid and not controlled by their physician, and all of a sudden they're hooked to heroin. So I think a lot of these do start that way, and the more we can get the public's expectations down and physicians' expectations down of what they have to do to control acute pain, the better off we're going to be.
One last comment on this tool, which I think, again, is phenomenal, is, have we ever thought of putting this out at the Federation to demo this, to let other states see it and maybe, maybe do something similar or just gets the word out, I think that would help. I mean, if this prototype in other states, I think that's a positive, if nothing else.
I think that's a good idea, especially after we have it robustly fleshed out with maybe an introduction video and all the other things we talked about when it's ready for prime time. Because you remember we were together at the FDA with Gottlieb, and he was really impressed with that. Even the granular data we had of lists. Imagine graphically, it's even more impactful.
Yeah, and maybe I don't know what our interface has been with the new FDA, but I mean, changing leadership means they forget who you are and it's a new regime comes in. I mean, is this something we want to, maybe knock on their door again and say we've got? And is it something that you guys are interested in, et cetera? I don't know, just a thought.
Just, might I suggest that because we do have such good feedback, and I do think we really need a clinical eye on something like this before we go live with this, that for next steps, perhaps we can send, Stuart, if it's possible, send the what we call the sandbox tool out, right? The one that's not live, this that you're looking at now, send this out to all of you so that you can play in the data a little bit and make some additional observations for us as we continue to work on this, on the feedback that you've already provided to us. And then we can come back to you in May with kind of further enhancements of it before we turn it on for the public.
Does it make sense to maybe get a sample of prescribers to actually work with us? Because I know we're here, but I mean, specialists in each of the area, maybe to give their feedback. I mean, is that a thought we would want, just a sampling? I don't know. I'll toss it out.
Well, it could be, but I think an initial step would be us, like Dr. Reddy, myself, who probably write them all the time, Dr. Feibel as well, who writes them for Acute. But, Reddy and I can kind of look through the chronic eye, and, we have Dr. Johnson, who probably writes some stuff too for her post-op, work. We could probably dabble first for the first month and then go from there.
Well, I don't disagree, and I don't know how comment is. We're a little biased in terms of the regulations and kind of, being attuned to that. I wonder if the normal prescribers out there is diligent.
I can work with the pharmacy board as they are with their project to make sure that the data is accurate. And moving forward, I could reach out to them and throw that idea to them, as well as they're going to be reaching out to some prescribers to make sure that the data collection process is going smoothly. We can utilize that same set of prescribers that they're reaching out to.
Well, great feedback, everyone. To summarize, it sounds like you guys are going to go back to the Board of Pharmacy, have discussions with them about data and accuracy and integrity. It sounds like we might be making some tweaks to the current website, possibly a video, maybe some FAQs, and then allow some of us to see the sandbox, so to speak. And then I guess we'll reconvene in May or June and go over again. Is that right?
That's great.
Okay. If there are any other comments, please let me know. And if not, we'll take a motion to adjourn.
I move to adjourn.
Right.
Second.
And a second. All right. All in favor, say aye. Aye. and okay. Thank you, guys.
Thank you.
See you soon.